Hello. So, today let's see what we're gonna do. Review general, introduce you to the knee joint, the ligaments and the menisci of the knee joint. Talk briefly about a muscle we'll cover again after the break called popliteus. Some of the injuries that can happen to the ACL and the PCL ligaments. Discuss some stuff about knee mechanics, some of which you may know, some you may not. What a Q angle is and what's called the screw home motion of the knee with the knee locks on extension. So all these things are basically what we'll do today. So last time we talked about the hip and its mobility and some of the issues with regards to the balance between what the ligaments are trying to prevent and the muscles that try to move the hip, and how there's this imbalance between muscles on the medial rotators. There's only a very few of them that can do it, and a whole bunch of lateral rotators, including a very solid one called gluteus maximus. I'll give you this figure, the bird's eye view of the femur fitting into the acetabulum, to give you an idea of how these things can rotate. Again, I encourage you to look at them in the lab if you're not clear what's going on. For medial rotation, the anterior fibers of gluteus medius and minimus are in front of the center rotation of the femur. They come back and attach to the trochanter in such a way that they can cause internal rotation. Of course, all of these muscle fibers from both of them are going to be pure abductors. That's what they really want to do. To some extent, although Moore doesn't address it, some of the more posterior fibers of things like gluteus medius are actually behind the center of rotation. So kind of like deltoid, the posterior part of deltoid could externally rotate the shoulder, the anterior parts could internally rotate, and the medial one really is just an abductor. If all three are active, it's primarily abduction. The same for medius at the hip. It's the analogous muscle. And also tensor fasciae lata is quite in front of the center of rotation. So although it likes to flex because it's in front, it can also internally rotate. Okay. All the other ones, to some extension, exception being obturator externus, it's almost right on the line of the center rotation of the joint, just a bit posterior. So its force, because it's coming underneath and around the neck before it inserts, is primarily trying to pull the head into the acetabulum. Okay? But as you can see, if this goes backwards now, if you actually do start to get into external rotation, then the distance between the line of the center and the pull of the muscle is going to get bigger and bigger and bigger and bigger. And you'll learn in biomechanics that that's called a moment arm. That's the distance from the center of rotation. So if you've got a screw, you've got a socket wrench, you put it on, or a bolt, you don't go right up next to the door and try to do it this way. You go out, so you can now torque the wrench. Think about opening a door. So if you go to open a door, a big wide door, you don't go right next to the hinge and try and push it open. There's too much weight. You go to the other side of the hinge, you push, and that door goes open easily. That distance is called the moment arm. And so these guys are taking advantage of it. In fact, if you look at obturator internus, although it takes its origin here, it pulls a UE right around the spine of the ischium before it attaches. It's got a huge distance from the center of rotation, and it's pulling in the exact perfect direction. So that's an extremely strong muscle that's joined by two little guys to help with external rotation. Likewise, think of things like piriformis, quadratus femoris, and of course the big strong muscle has a huge capability to externally rotate. This was also summarized in, I think, a table. It's really frightening to look at it at the beginning, but it lists everything. There's a few it doesn't talk about. Things like pectineus is a medial rotator, but if you look carefully in the book, he does hint at it. The problem is it goes almost right through the center rotation of the hip. So it's not until the hip starts to internally rotate that now it starts to get its own moment arm and can add to the internal rotation. Okay, so I encourage you to look over this one. The knee. Usually a good percentage of you have had some kind of damage to it, or you know someone who has. So it's the articulation between the femur and the tibia primarily, the fibula kind of goes along for the ride. So it's not like the radius. It's not actually involved in the joint itself. It's a different orientation. The joint is primarily between the femur and its medial and lateral condyles, with the medial and lateral condyles on the plateau of the tibia. And the condyles are the area in blue that would be covered with hyaline cartilage in life. And if you look at the femur, it's basically this big arching interaction with the top of the tibia. So these condyles are quite extensive. They're all on the inferior surface, and they extend quite a bit posteriorly. So that when the knee flexes, the posterior aspect of these condyles now come in contact with the tibial plateau. And there's a groove in the middle called the eminence, right in here, and a hollow in the back between the condyles called the intercondylar fossa. This gap allows you to go into flexion, but yet still have this eminence right in the middle. So it adds a bit of stability to the joint. The last bit of stability comes from the ligaments that are housed in here, and we'll come to them next. So you do have a fibula with a neck and a tibia. So you're going to have a superior tibial-femoral joint. It's not very mobile. It's got ligaments. We'll talk about it when we get into the lower limb. Anything else that's important on this? No. Okay. So same figure, but new from Moore. It goes on and talks about the fact that this eminence has two sort of tubercles on it, on the anterior surface. So the medial and lateral intercondylar tubercles are on that eminence. And that's because things attach to them. Here's the posterior image. I point out, well, this was pointed out to me in the lab yesterday. In this x-ray, it says neck of femur. I don't think so. Right? That's not the neck of the femur. That would be somewhere way up there. So this is obviously just a typo. It's the neck of the fibula. And you're not responsible for the x-rays, but if you look at them, you can figure it out. You can figure out what everything's going on here. Okay. Oh, before I go on, just a second. Go back. So if you think of the articulations of the knee joint, there's three. Again, you're going to have a articulation here called the lateral femoral tibial articulation. So that's the lateral condyle of femur, lateral condyle of the tibia. There'll also be a medial one, the medial femoral tibial articulation, medial condyles interacting there. But there's also the articulation of the patella with the femur. So this would be the femoral patellar articulation. So the patella never actually talks to the tibia. It only talks to the fibula. It only interacts with the fibula. Or femur, sorry, not fibula. Now you don't screw it. So there's three articulations for this joint. You'll see it's called a hinge joint. But you see it does a lot more than just function like the elbow does as a hinge. It has a whole lot more mobility than that. Okay, so the ligaments. What they've done here is an anterior view of the right knee. So they've cut through the patellar ligament, which would usually be right here, attaching to the tibial tuberosity. So it runs from the apex, this is the undersurface of the patella, it runs from the apex of the patella and slightly on either side to go down and attach to the tibial tuberosity. Patellar ligament because it's running bone to bone. Attaching to it would be the quadriceps tendon, or the patellar tendon, okay? And all we've done is reflected it to get it out of the way so we can peek into the knee. The femur has been put into flexion. So you're looking at the inferior surface of the femur. The shaft is going into the screen. So you're looking at a flexed knee joint. You can see the condylar surfaces. So the lateral femoral condyle is not as big as the medial condyle. The medial one extends quite a bit more into the anterior. This is a flexed knee, so anterior would be up. This would all be covered with cartilage. Four ligaments that are primary stabilizers for the knee joint is on the medial side, so running from the femoral condyle down to the, or epicondyle down to the tibial side, or of the medial side of the tibia, is a big thickening of the capsule. So this is the tibial collateral ligament. That's its new name. It used to be called the medial collateral ligament. I'll probably flip back and forth between the two of them. The medial collateral ligament is just basically the medial side of the joint capsule gets really thick. And it's wide too. So it's quite a wide ligament, and it's quite thick. And it forms the inside of the joint capsule. Okay. And it's going to be continuous anteriorly with fibers until eventually it melds up with the anterior part of the joint capsule, which is the patellar ligament. So actually the anterior part of your joint capsule, there's a thickening of the joint capsule. That's the patellar ligament. On the lateral side, what used to be called the lateral collateral ligament is the fibular collateral ligament. It runs from the epicondyle on the lateral side of the femur, and it's a cord. It's quite a tight banded cord, It's slightly posterior, you can't see from here, but on a lateral view you see it's actually back a bit. And it runs right down and inserts onto the head of the fibula. And that's the one you can palpate quite easily. Do this again without killing myself. You find the head of the fibula, you realize it's actually quite back a bit. And you go just up from that, and as you bounce and rub, what you're rubbing on is actually the fibular collateral ligament. Notice it's not part of the joint capsule. So this is a whole separate beast, right? Medial one is the thickening of the inside of the medial capsule. This one is separate from the capsule. The capsule is inside of it. So it's an extrinsic ligament. It stands all on its own. Where the fibula is joining up to the tibia, there's a small joint capsule here as well, and a ligament there. You won't really have to worry about it until we get to that. But there's two other ligaments right in the center of the femur, basically, and running from tibia to femur. So they're so-called origins on the tibia. Their insertions are actually on the femur, so they run superiorly. Don't care, just so that you know the two attachments. There's one called the anterior cruciate ligament. There's one called the posterior cruciate ligament, ACL and PCL. The way I remember their direction, to the right side, take my middle finger, oops, that was dangerous, right? I almost did that. Cross it over the index finger, and I run the middle finger at about this angle. So from here down, slightly anterior, medial, and then I run the pointer the other way. So they're crossed, that's why they're called cruciate. And in fact, the posterior cruciate runs from the posterior aspect anteriorly. So they're kind of like, let's get this right. I can't do it that way. Kind of like this. That's how they run. So they're crossed. And they run right in that gap between the condyles. So the anterior one is taking its attachment on the, you'll see in a second, the anterior aspect, slightly medial onto tibial plateau, runs posteriorly, and actually inserts onto the wall of the medial surface of the lateral condyle. So it's going up into the gap, and attaching up here. The posterior one actually comes from the posterior surface, runs anteriorly and medially to insert on the medial side of the lateral side of the medial condyle. So that's how they cross. It'll be easier to see in a second. There is another ligament here that runs in front, ties two of these things called menisci. These are fibrocartilaginous discs, you'll see in a second. There's a medial one and a lateral one. And this is the transverse ligament of the knee. It's another one that you should know. Okay, that's that for that one. Posteriorly, try to give you a different view of these again. You can see the fibular collateral ligament. Again, it is quite posterior, where it attaches to the head of the fibula. And then the big thickening of the capsule is the tibial or medial collateral ligament. There are these menisci. They are basically big fibrocartilaginous discs that sit in between the condyles of the femur and the tibial plateau condyles. You'll see them in a second. So here's the attachment for the anterior cruciate ligament. So it's going to be on the right side, so it's running again from the sort of medial surface of the lateral part of this condyle. It's running in an inferior direction anteriorly. It's going to insert on the front part of the tibia over there. The PCL comes from the posterior aspect here, runs anteriorly and in a different direction, crossing medial to the ACL, running anteriorly and inserting on the lateral wall of the medial condyle. So they kind of have this crossing pattern. Okay. What else? The muscle of interest here is called popliteus. It's a very strange little muscle. It runs, actually it takes its first attachment is up on the lateral epicondyle. It actually runs between the fibular collateral ligament and the rest of the knee joint through a gap in the joint capsule. Runs, and then the tall muscle inserts onto the posterior surface, superior posterior surface of the tibia. This line here is called the soleal line. It's just above that. You'll see this kind of attachment on the skeletons in the lab. It's actually running right through the joint capsule and separating the fibular collateral ligament from the joint. And I point out its line of pull. What would this be doing? If this contracts, the only thing it can do to the femur is laterally rotate it primarily. You could think, well, maybe it'll be some kind of a flexor, a weak flexor of the knee joint. Yeah, it probably is. But it's reaching up and grabbing the femur on the outside. If it contracts, it's going to try to rotate it laterally. So keep that in mind. Here are the figures from Muirmore, a little better drawn. The same idea, you can see the condyles, you see the big difference between the inferior surface of the medial compared to the lateral. You see the menisci, wedgie discs, you see a better picture of them in a second. And it runs, the ACL runs from the front, sort of anterior surface of the tibia on the medial purpose, up, and attaches on the inside of the condyle posteriorly. The posterior cruciate here is going to run instead more in this direction, okay, and it's going to attach to the condyle over here. So this is the attachment of the posterior cruciate. Kind of neat. Everything else is the same as the previous figure. So here's a better view. What they've done in this one is they've sort of cut halfway through, giving you a mid-sagittal cut through the femur, taking it out. So taking away the medial part of the femur, left the tibia alone, cut the posterior cruciate ligament to get it out of the way, but that's the line going from tibia up to insert inside medial surface of the lateral condyle. So this would be your ACL. So it's not just doing this, it's going this way, right? It's going in an angle. But you can see its line here is not going to be very happy with the relationship here if you try to separate the femur and the tibia. It's going to want to prevent that separation. It's not going to want to let the tibia be pulled forward relative to the femur. If you flip it around, you cut the lateral side of the femur, get it out of the way. So now you're looking at the medial half of the femur, mid-sagittal cut. We've gotten rid of the ACL ligament and cut that to get it out of the way. This is again the line of the pull of the posterior cruciate ligament, but notice the knee here is slightly flexed. So this one becomes tighter and tighter and tighter the more the knee gets into flexion. The previous one gets tighter and tighter and tighter the more you get into extension. You start to flex the femur down, this would start to loosen up a bit. So they're tighter at different positions. This is on extension, oops, this one's on extension, this one's tighter on flexion. Okay. And they cross. So here's another view. What they've done is they've cut the ligaments and they've taken the femur right out of the way, and it's a bird's eye view down on the top of the tibial plateau on the right knee. So they cut through the patella itself. So there's your patellar ligament. Remember, this will form sort of the anterior capsule, the front part of the joint capsule. Here's your head of the fibula. They've cut through the fibular collateral ligament. So that's just the stump of it. But notice the difference between the size of it and the tibial collateral ligament or medial collateral ligament. This is big thickening, medial side of the joint capsule. So it's not as cord-like, it's quite a big band. And here's the transverse ligament of the knee going right across the front. If you notice, there's the line for the anterior cruciate ligament. Remember, this is where it would start its journey from the sort of the medial side, anterior part of the tibia, and race backwards up to then attach posteriorly on the medial surface of the lateral condyle. PCL, slightly different path, goes this way, and attach in the front to the medial side, the lateral side of the medial condyle. But they end up crossing each other. The menisci are these funny gray pillows. The blue stuff would be hyaline cartilage, and these menisci have different shapes, and to some extent, a different job. The medial meniscus here, you notice it's thin at the front, it gets wider as you come posteriorly, and it's all C-shaped. It's like a C. It's bound down or tied down to the tibial plateau all the way around by ligaments called coronary ligaments. The lateral meniscus is tinier, AP, in the anterior posterior direction, and it's more oval-like. And the actual articular surface is slightly smaller and lateral to medial, but it curves almost right around to join its other end in front, but they're also bound down just below where the ACL is. So the ACL attachment is just behind where the medial meniscus takes its origin. And these things, if you were to cut through them in cross-section, whack, okay? If you were to look at them through cross-section, it's gonna be like that. So you cut through, let's say mid-coronal cut, bang, and you're looking at the medial surface of the medial meniscus. As it goes in, this edge up here is quite high. It's like a stadium. So these are the high seats all the way around the perimeter. And as you get close to the middle portion here, it's very, very thin. And this is where you can get tears in this guy all along these thin borders. You also get tears because it's tied down tightly by these ligaments. The worst case scenario for the medial meniscus is actually tied to the medial collateral ligament. So the tibial collateral ligament is strongly attached to the meniscus. So you end up with a tear of the MCL, tibial collateral. You usually end up with a tear of the medial meniscus as well. Yeah. Very close to it. They do say it attaches to it, yeah. And more he says that. I don't know, I never scoped to find out, but on a cadaver, the attachment looks extremely close. The fibular collateral doesn't attach to anything. But you can notice the size of it. And actually, the lateral meniscus isn't as tied down as much. So if you watch during motion of the knee joint, the medial one doesn't move a whole lot. The lateral one can kind of glide a bit on top of the tibial plateau. So it's known to move just slightly forward and backwards. But because this transverse ligament bounds them together, it's sort of prevented from floating all over the place. Okay. So here's these images from your new board, same ones I've been showing you. If you think of the injury, poor guy here making his tackle, what you've got is here's the femur, the tibia and the fibula of the left leg, his left leg. But he runs them over, so you've got now a flexed knee joint. You've got a planted foot, so the foot is externally rotating. That means it's taking the tibia along for a ride. It's trying to rotate the tibia. It's flexing the knee. And what do you get? Well, the only one that's really quite safe here is the fibular collateral ligament is actually being unloaded, but the ACL will get torn. Medial meniscus may tear because the tibial collateral ligament is also being sheared. So when you do this, you're straining this direction of attachment for the ACL. You're actually trying to separate the medial compartment here, so you're actually straining the MCL. You damage the MCL, more likely you're going to tear off parts of the medial meniscus as well. Yep. Have to be louder. Can you hear me? Why is it that the ACL has really bad blood supply? First off, it's thinner than the PCL. That's why you're more often likely to damage ACL than PCL. PCL is a bigger, thicker ligament. And the last thing is that you got to remember, tibial collateral or medial collateral ligament is a thickening of the capsule. So it's actually got good blood supply. And although you can tear it, it can sometimes heal quite nicely. Some people, daughter number one, 28-year-olds, I think she's done this knee 4 or 5 times, but always grade 1 or grade 2 tears. Then she doesn't do anything for a month, and then she goes back to play soccer, and things happen. So this triplet is called the unhappy triad when you damage all 3 of them. Sometimes it's just a type of motion that you are enough to strain, if you think of it in priority, enough to strain just the ACL, partially tear it or tear it without damaging the other ones. You don't have to have that happen. But if it's a really bad motion, it'll tear. There's this sort of a little mock-up from the web I stole. That would be the torque that happens and pop. So internal rotation of the femur on the tibia with flexion and bang. Like how it sort of pops at the end there? Have you ever had that? You know exactly what I'm talking about. Okay. So, Michael Owen, Liverpool, England, that's the motion right there. No contact, just body weight. And the last thing that did it in is he lost his balance and couldn't get his hand out fast enough, so he fell over backwards on his leg. Bang. So that's the mechanism of injury. You're trying to, if you think, This is the ACL. You're actually torquing the tibia. Now doing this to it. Okay? So that's pulling right on the line of the ACL. And again, it's not that thick. It's really bad blood supply. I think this is when he was just before the World Cup. He's playing for Liverpool. And he never played again the same way after that. So if you think about the ACL, if you put the leg into a flexed position, you're right along the line where the anterior cruciate wants to prevent the femur from sliding posterior relative to the tibia, or the tibia moving anteriorly relative to the femur. Sorry. Get that with my head. So this type of thing is called an anterior drawer sign. My dad tore his ACL when he was about 50, just as I was getting into this stuff. I remember sitting him down, grabbing one leg, and he'd pull on it, no problem. Grabbing his other leg and pulling on it, and his leg just kept coming. There was nothing preventing the tibia from moving forward. It wasn't painful, but it had been torn for about a month. This anterior drawer sign is how you test the stability of the tibia-fibula relationship in a flexed knee. You try to pull the tibia anteriorly to the femur. Why? Because the ACL doesn't like that. If it's not there, you have a highly mobile joint. Okay. So think of it also as being when? In hyperextension of the knee. Remember I showed you that image that as you go from flexed, it's sort of tight. But as soon as you get into extension now, the ACL is actually pretty tight. So if you go from extension to hyperextension, i.e. someone hits you at the knee and your knee has to bend the other way, the way it doesn't want to go, then that's where you can tell tear the ACL, especially if you're on the ground. The flip side would be the posterior cruciate ligament wants to prevent the femur from sliding anteriorly relative to the tibia, okay, especially with a flexed knee. Why? Because as you flex the knee, the PCL starts to get tighter and tighter and tighter. What does it want to do? It wants to stop. In a flexed knee, the tibia either going backwards or the femur coming forwards over top of the plateau. That's its line of pull. It wants to stop that relationship. So again, here would be the posterior draw sign. If you have someone flexed, just try to push their tibia out from underneath the femur. PCL should prevent that. If it's been torn, you'll find you'll be able to move the tibia much more posteriorly than before. Okay. If you think about, well, before we go on, if you think about it, when are they injured? You know about the ACL injury. PCL, the most common injury, is when you land on a flexed knee right on the tibial tuberosity. So you land right like that on the ground. What you're doing is you're driving the tibia underneath the femur. Whoops. That's going to go after the PCL. So usually PCL damage is on a flexed knee hitting the ground somehow hard, where the force is taken through the tibia, not the femur yet. And the first thing to go will be PCL ligament. So if you think about the knee joint, in extension, there's not a lot of motion between these two as far as internal and external rotation. I'll show you why in a second. But if you start to flex the knee a bit, you can actually rotate it. So if you call my wife if I hurt myself. If you're flexed, you can actually move the tibia quite a bit into the external and internal rotation. Internal rotation, maybe 10 degrees. External rotation, about 60. So you can externally rotate the tibia relative to the femur when the knee's flexed quite a lot compared to internal. And why would that be? Well, if you think about these collateral ligaments and the relationship to the cruciates, if you try to internally rotate the tibia relative to the femur, that cruciate cross gets tighter. It's not going to like that. It's not going to want the tibia to move in internally relative to the femur. So they get tight on internal rotation. When you internally rotate, actually the collaterals kind of get slack. They don't care. Other way around, as you externally rotate the tibia relative to the femur, now what you've done is you've uncrossed the cruciates. You're actually shortening them to some extent. So you can go quite a bit. Again, 50 to 60 degrees of external rotation before the things that don't like it, collaterals, start to get tight. So it's the collaterals that prevent the external rotation. It's the cruciates that prevent the internal rotation. So if you think of the articulation between the patella and the femur, why have a patella? Why even have one? Well, it's this idea of where's the center of rotation of the femur? Well, it's right basically through the center of the femur. As you flex, you kind of rotate around that point. Well, who's going to want to move the femur into extension? The quads. And rather than running right along the surface of the femur onto the tibial plateau, they're actually pushed out a bit because they attach to this bone, and it increases the distance of the line of force from the center of rotation. Sound familiar? So what we've done is we've increased the length of your wrench, if you wish, by a centimeter or so that the line of force is out here relative to there rather than there. If the quads went right close to the center of rotation, it'd be a horrible extensor. Wouldn't have any strength. So you're talking about four big, thick muscles that now have a couple of centimeters moment arm from the center of rotation of the femur. So they're very powerful at that. And actually having that patella there is important because it helps increase the distance from the line of force from the center of rotation. Lastly, because it's a bone with its own articulation of the femur, remember that's the middle one, it can actually act as a way to help reduce damage to the bones themselves. Just asking the bones to interact with each other. It's not asking the tendon and the patella or the tendon and the ligament to go through it, which would be highly wearing. So usually when you see these sesamoids, remember the two in the thumb? That one, it's designed to increase the distance of the force production of the quads. It's also designed to help reduce the damage to the knee joint when you're repeatedly flex and extend it. Look at the posterior surface of the right patella. There's a sort of a weak little line down the middle here. The middle articular facets are smaller and not as much as the lateral articular facets. If you pick up the patella, you look at the undersurface, the big surface, it's always on the lateral side. So find the apex, you find the big surface, and you go, okay, that's our right patella. Because the medial surface here is smaller, and there's a tiny, tiny surface here as well. The numbers, so there's inferior facets, middle facets, and superior facets, both medial and lateral ones. The numbers here and the color basically line up with what part of the patella is interacting with the femur when. On an extended knee joint, it's the lower ones. The lower part of the patella is actually interacting with the condyles of the femur. As you start to flex the knee into the middle portion here, that's where you end up with number 2s playing along. Finally, as you get closer to almost full flexion, it's actually the top part of the patella that's now riding along the femur. And finally, with a fully flexed knee, actually very little of the patella is in contact with the femur. It's just the medial lip of it. I encourage you in the lab to just look at what happens when you move this joint around, how the patella will track. Because the grooves in the condyles and the way the surface is designed is basically to allow the patella to groove through the notch in those condyles. It's supposed to come right up the middle. And the lateral condyle has a little bit more of a ridge than the medial one. And that's to prevent the patella from going out laterally, so help to track it. So nice quick image by Moore on that one. So there's a thing called the Q angle, and it's very simple. If you think of someone standing, remember we have this angulation in the femur, angle of inclination. Sometimes it can be more profound, changes with age. It's more straight up and down in young kids. But what it does, it puts the femur off to one side. But if you notice, even in the skeletons, when you're standing, don't look at me, I'm full-legged. You look at the skeleton standing, there's an angle from the hip down to the knee, which is progressively becoming more and more medial. So the femur is not vertical. The femur is pointed, so it runs from the hip towards the knee. It's got an angle. Okay? The tibia, on the other hand, is usually vertical. The tibia runs vertical. So the tibias are on the mid-side, and the femurs are coming from the outside to join them. So there's an angle here at the knee joint. This is called the Q angle. You basically take a line from the anterior superior iliac spine, you draw it right through the center of the patella, and then you go to the tibia, and you draw a line from the tibial tuberosity right through the patella. And that angle in between them is a Q angle. I don't know what the actual values are, about 10 degrees, something like that. So it means that this isn't a straight line, there's a slight turn to it. Now, if you tend to have wider hips, and remember this angle of inclination is profound, then the angle that the femur takes is going to be a lot more, and your knees are going to be closer together, and the line between the patella and the tibial tuberosity is going to be a lot greater. Now your Q angle is going to become more profound, and you can see the bend here. I always think of it as an archer's bow, and here's the line of the string going on the bow. Well, what's it want to do? If you pull this way, it's going to want to go that way. It's going to want to put the patella over here. So this scenario with a greater Q angle is called genu valgum. Valgum, not knee. Okay. And the tracking for the patella is sometimes more challenged by trying to keep it to going straight and not wanting to wander off outside. If it starts to do that, it dislocates. Some of you experienced that before. Lateral dislocation, very common. Medial, almost never. The flip side is someone like me. You draw a line from my ass through my patella and then through my patella onto my tibial tuberosity, and I am genu varum. Okay? I can ride bulls for a living. So hips, the angles of femur is not as profound. It's almost vertical, almost. But then from my knees down, there's an angle, acute angle. So if you draw me, very tiny Q angle. And the other problem I have on this leg is the tibia is not just doing this, it's rotated. So if you draw a line, you can see there, draw a line through my patella, down my tibial tuberosity, that's fine. Patella, tibial tuberosity is over here. So think of that. Tibial torsion has now moved my tibial tuberosity that way, relative to the patella. So it's quite profound. So genu varum durum valgum, and this whole idea of the Q angle, and it's called a Q angle because it's caused by the quadriceps force. Which way is the quads pulling the patella? Well, it's going to pull it towards, roughly through the direction of the ASIs. ASIs is going to go. So if your Q angle is not that profound, you're not going to have any problems with the patella tracking medial-laterally. If it is profound, as the force comes up, the patella is going to want to wander off that way, and you'll tend to dislocate. The thing preventing that, remember quadriceps, the vastus lateralis, medialis, not only do they insert into the patella, they also have those connective tissue components that insert on the side of the patella, the retinacula, medial and lateral retinacula. So if you have a strong vastus medialis, or you make it stronger, and you have a big Q angle, it'll prevent the patella from wanting to go that way. You'll have to try to track it more along the line of the quadriceps force. So you do a lot of medial quads exercises, then you're needing force vastus medialis to work to make it stronger. Okay, again, here's your Q angle idea. So when you're sitting down, what you can do is you can palpate and move around the patella. Put someone into a nice, relaxed, almost extension position. You should be able to play around with your patella. You can move it medial and laterally. You'll feel the resistance. Is it easy to push medial or laterally? And then you can actually get underneath and feel the lateral articulation if you want. I would do this on yourself. But keep your leg relaxed. Your muscles tight, you can't do anything. But it's this groove where the finger is right there, the guy's thumb. That's how the patella is supposed to track on an extending leg. That's why the condyles are designed the way they are. They help to keep the patella in that groove as you're going up. And that's why the undersurface of the patella is not flat. There's that ridge, there's this tiny medial surface, and the lateral one is quite profound. Again, to put it down into the condyle so it doesn't want to dislocate laterally. Okay, one final concept about the screw-home motion of the knee joint is here's a flex knee going into extension. As you get to the last few degrees of extension of the knee in an unloaded knee joint, again, Tim will do this. Okay, so relationship, as I get to the last bit of extension, the tibia will rotate just about 5 degrees. So my foot's sort of going to go, okay, as I lock in. So this last screwing home motion in an unloaded leg is as you bring the tibia up, it loads this way. Remember there's condyles, there's enaminants, there's ligaments, all the muscles around it. As you do that, you lock basically the tibia and the femur. Great. That's when the limb is free to move. Remember, this is all relative motion, femur and tibia. Okay? If I'm extending the leg, who's able to move? The tibia is able to move. If I'm standing, weight bearing. seated position and then standing up, tibias can't move. So what happens is on the last few degrees of extension, as you get up, both femurs rotate medially, oof, and they lock you in. Okay, so there's a 5-degree of rotation of the femur relative to the tibia at full extension. Now, you can pretty well stand with very little muscle activity. You do that, you get your gluteus sort of pulling on the iliotibial tract, the tensor fasciae lata. Now, if you're doing it well, you can actually totally relax your quads and hamstrings. So it's just that. You're actually standing on so-called locked legs. So this mechanism is called the screw home mechanism. Unloaded, the thing that moves is the tibia into an external rotation. The knee is loaded, you're going to have the femur going internal. Okay, try it. Everyone can put dots in your patella and your tibial tuberosity. So you get the last few degrees of extension when you're unloaded. All of a sudden, tibial tuberosity will rotate out over 5 degrees. So remember popliteus, the tiny little muscle, right side, back of the tibia, reaches up across the back of the knee joint, goes between the fibular collateral ligament and the femoral condyle, the lateral femoral condyle, and attaches there. What does it do? When you're locked in, the only thing it can do is externally rotate the femur. So that's what they do. They go in, remember, on extension, both femurs are internally rotated, popliteus goes up, unlocks the joint. So popliteus is involved in unlocking this screw mechanism by causing relative motion of the femur to the tibia of external rotation of the femur on a planted tibia. Isn't that cool? This tiny little bugger. Okay? So you're standing, the first thing you do before you generate any kind of force to start walking, take the clutch out, and off you go. Okay? So this is the first thing that happens on walking. So you have to control the screw home mechanism. So, last thing we didn't talk about yet. I don't know if I have a figure for that one though. Let me just check. I think I do. Yeah, okay, here. This is the graphic at the beginning. You're looking at the left leg from the medial side, so this would be symbolically the medial collateral ligament. It's not really a band. There's the fibula over there. On extension, watch what happens to the femur. Whoop. Right? Just at the very end, it's going up, and then it rotates medially. That is the screw home mechanism. And if you watch with the patella, it's not really tracking perfectly, but if you notice, the patella never interacts with the tibia. It kind of glides up and down. On extension, it's the inferior part of the patella. On flexion, it's the superior part. You really got flex to move over into the medial articular surface. But if you just notice that last bit of extension, bang. That's the screw home mechanism. Second thing you should notice is the way the femur rocks on the tibial plateau. If you are, I'll try drawing this. Okay, so femur, tibial plateau. If you take this and you go and flex it, what's it going to do? It's going to come out here, right? It's going to roll like this. It's going to basically roll off, right? As you go into flexion, it's just going to roll right to the posterior aspect and fall off the edge. So it can't do that. Instead, what it does is it spins. So it starts to roll, but the parting contact slides forward. That's called translation. So you're rolling, translating. That's called spin. So going from an extended position to a flexed position, who helps to do that? ACL, right? The ACL is lined up this way. So as you go to try and go backwards, you actually have to drag the femur back on top of the tibial plateau. And that's the ACL. The ACL is designed to say, no, I'm not letting you roll away. We're going to take this roll, translation, and turn it into what we call spin. So the whole thing spins on top of each other from extension to flexion. Put it the other way around. Now you know I'm glad there's PowerPoint. How, if I just go into extension, it's never going to come up here. How do we get it up there? PCL. So from here, actually it's more like this, sorry. I'll do it this way. Okay. You go from here, you end up like this, right? You're gonna roll off the front edge. So if you're in here, you roll, you're gonna go right off the front of the plateau onto when you try to extend. So once again, something is trying to drag as you go into extension. Something is trying to drag the front of the femur condyles back onto the plateau while you go into extension. Posterior cruciate ligament is designed to do that perfectly. So the two ligaments, ACL and PCL, work together to help you get spin. So not only can the knee joint act like a hinge, it's a rolling hinge. We now know it has a bit of motion and an open flex joint of internal and external rotation too. That doesn't exist when you're locked on extension. So this whole idea of the cruciates are really important for normal joint motion. I tried to find a schematic for that, but I couldn't find one. But you can see here, it doesn't roll right off the plateau. And as it comes back onto extension, it doesn't roll off the front. So it's spinning here. And it spins because of the ACL and PCL. ACL when going into flexion, PCL when going into extension. That's why if you have a damaged PCL, what's the most terrifying thing? Running down the stairs at Wreck Beach, right? If you're flexed, what is going to happen if you don't have a PCL? Femur's going to glide right off the front of the tibia. So that's why you have to develop a lot of muscle strength and stuff to compensate for that. Don't need to know it, just an interesting fact. You'll find out later maybe that the ACL and PCL actually have multiple parts to them. You think of here's a nice picture, a sculpt picture of the posterior cruciate ligament. That's two parts, an anterior lateral, posterior medial. Same with the ACL. It has two parts that have been cut over here. So there's more to learn than we're just telling you now when it comes to these ligaments. Okay? Perfect. Have a great week.